Welcome to ICU Primary Prepcast,
Hi, my name's Maddi.
and I'm Swapnil. And today we are going to discuss about antihypertensive agents in intensive care. Are you ready?
Yes.
So, Maddie, can you please classify antihypertensives according to their mechanism of action and give an example of a drug from each class?
So blood pressure is determined by cardiac output multiplied by total peripheral resistance and involves regulation of vascular smooth muscle tone, cardiac output, and intravascular volume. It is controlled by a complex interplay between the autonomic nervous system, humoral mechanisms, especially the renin, angiotensin, aldosterone system, and vasoactive substances released from vascular endothelium. Thus, all antihypertensives involve interfering with these basic control mechanisms. Antihypertensives can be broadly classified into 5 separate categories: Adreno agents, direct vasodilators, calcium channel blockers, those that affect the renin, angiotensin, aldosterone system, and diuretics. We'll briefly outline the mechanism of action behind each group. Firstly, adreno receptor agents. These can be divided into central and peripheral agents. Central. These are mainly alpha-2 agonists, such as clonidine and methyldopa. They work by acting on alpha-2 receptors in the brainstem, which inhibits sympathetic vasomotor centers and thus decreases sympathetic outflow to the peripheral vasculature. Interestingly, agonism of alpha-2 receptors in the periphery results in vasoconstriction. However, this is negated by the central effects, resulting in decreased blood pressure. Peripheral adreno receptor agents include alpha-adrenergic antagonists. These cause vasodilation by antagonism of alpha-1 adrenoreceptors, which reduce phospholipase 3, DAG, and IP3, thus reducing intracellular calcium. An example of this is prazosin. Some alpha-adrenergic antagonists also block alpha-2 receptors in the periphery, which causes an increase in intracellular cyclic AMP, thus inhibiting myosin light chain kinase and resulting in vasodilation. Alpha-2 receptors are also located on prejunctional sympathetic nerve terminals and act as a feedback mechanism to inhibit further release of noradrenaline. Therefore, antagonism can result in increased noradrenaline release. Phentolamine is an example of an alpha-1 and alpha-2 antagonist. Beta-adrenergic antagonists are also an example of peripheral adrenoreceptor agents. These include agents such as Metoprolol and work by binding to beta-adrenoreceptors and thereby blocking the binding of noradrenaline and adrenaline, thus inhibiting sympathetic stimulation. Within the heart, this is mainly via beta-1 antagonism, resulting in decreased inotropy and reduced heart rate, thus resulting in decreased cardiac output. Finally, there are mixed antagonists such as labetalol, which act by antagonism of both alpha and beta adrenergic receptors. The second broad category are direct vasodilators. These include those that act via nitric oxide, such as sodium nitroprusside and GTN. Nitric oxide increases cyclic GMP, which causes vasodilatation. Another direct vasodilator is hydralazine, which causes arterial dilatation by an unclear mechanism, potentially also via stimulation of cyclic GMP and inhibition of myosin light chain kinase. The third category are calcium channel antagonists, such as diltiazem. These bind to and block L-type calcium channels located in vascular smooth muscle, cardiac myocytes, and cardiac nodal tissue, resulting in decreased cardiac contractility, decreased heart rate, and vasodilatation. The fourth group are renin, angiotensin, aldosterone system drugs. These block the effects of angiotensin 2 and aldosterone, resulting in vasodilatation, reduced sympathetic stimulation, reduced sodium and water retention, and therefore reduced blood pressure. They include ACE inhibitors such as captopril and angiotensin receptor blockers such as irbesartan. The final group are diuretics such as hydrochlorothiazide. These lower blood pressure by increasing sodium and water excretion, thereby reducing intravascular volume and cardiac output. Loop and thiazide diuretics are also thought to decrease peripheral vascular resistance through vasodilatation and potentially by causing a sodium deficit, which reduces vascular stiffness. Aldosterone antagonists also reduce blood pressure in situations of secondary hyperaldosteronism.
Okay, let's consider a clinical scenario. A 60-year-old male presents to emergency department with a blood pressure of 200 over 150 millimeter of mercury and severe chest pain. He is admitted to the intensive care unit for urgent reduction of blood pressure. You decided to use glyceryl trinitrate infusion or GTN infusion. Could you please outline the mechanism of action of glyceryl trinitrate?
Glyceryl trinitrate is an organic nitrate which causes potent vasodilatation with a greater effect on veins compared to arteries. GTN requires enzymatic activation intracellularly, which releases free nitrite ions, which is then converted to nitric oxide. Nitric oxide subsequently activates guanylyl cyclase, resulting in increased cyclic GMP. This dephosphorylates myosin light chains, resulting in decreased intracellular calcium, thus causing smooth muscle relaxation. The end result is dilatation of veins, causing decreased venous return and thus decreased preload, arteriolar dilatation, causing reduced systemic vascular resistance and afterload. Furthermore, dilatation of coronary arteries can improve oxygen delivery, and this combined with a decreased preload and afterload reduces myocardial oxygen demand, thus making it a useful medication for angina and cardiac failure.
How does this mechanism differ from that of sodium nitroprusside?
So sodium nitroprusside is an inorganic compound and acts as a prodrug. It is comprised of a ferrous ion center associated with 5 cyanide molecules and 1 nitric oxide molecule. Sodium nitroprusside reacts with sulfhydryl groups, releasing nitric oxide, which activates guanylyl cyclase, increasing cyclic GMP and causing vasodilatation. Unlike GTN, it does not require enzymatic activation intracellularly, but rather releases nitric oxide spontaneously. Sodium nitroprusside has a greater effect on arterial compared to venous vessels, which is the opposite of GTN. However, both GTN and sodium nitroprusside cause cerebral vasodilatation and can cause inhibition of hypoxic pulmonary vasoconstriction, resulting in shunt.
Okay. Can you please briefly outline pharmaceutical and pharmacokinetic differences between GTN and SNP?
In terms of pharmaceutics, GTN is available in a variety of formulations and can be administered sublingually, transdermally, and intravenously, whereas SNP can only be given intravenously. Both SNP and GTN require dilution and special considerations when preparing the infusions. GTN infusion should be given via glass or non-PVC sets, as PVC absorbs GTN. SNP, on the other hand, is photosensitive and needs to be protected from light using aluminium foil. GTN can burn if heated, therefore transdermal patches should be removed prior to DC cardioversion. In terms of pharmacokinetics, SNP has poor oral absorption, whereas GTN is rapidly absorbed through buccal and sublingual mucosa. GTN is also well absorbed orally, however undergoes significant first-pass metabolism, thereby reducing its bioavailability to less than 10% if given orally. GTN has a large volume of distribution of about 3 litres per kilo, whereas SNP has a volume of distribution roughly equal to extracellular volume. Both IV GTN and SNP have rapid onset and offsets of a few minutes, making them easily titratable and useful as infusions. GTN is metabolized in the liver and red blood cells to di- and mononitrates, which still have some mild vasodilatory action and are excreted in the urine. The metabolism of SNP is much more complicated. It is rapidly metabolized by uptake into red blood cells, producing 5 cyanide ions and methemoglobin. The methemoglobin combines with cyanide to form cyanomethemoglobin, which is non-toxic. The remaining cyanide is converted in the liver and kidney by rhodonese to form thiocyanate, which can be excreted in the urine.
Can you please outline the mechanism by which a SNP or sodium nitroprusside can cause toxicity?
Sodium nitroprusside can result in toxicity via several mechanisms: cyanide toxicity, thiocyanate toxicity, adverse effects resulting from extension of its pharmacodynamic action, and finally methemoglobinemia. Firstly, cyanide toxicity. As described earlier, the metabolism of SNP results in the generation of cyanide. Mostly, this binds to methemoglobin to form cyan-methemoglobin or form thiocyanate, which is excreted in the urine. However, if these metabolic pathways are overwhelmed, cyanide binds to cytochrome oxidase, which inhibits oxidative phosphorylation and cellular respiration, causing histotoxic hypoxia. This results in lactic acidosis, venous hyperoxemia, confusion, tachycardia, and hyperventilation. The treatment is cessation of the infusion, application of oxygen, and administration of sodium thiosulfate, which converts cyanide to thiocyanate. Other antidotes include hydroxycobalamin, which binds to cyanide to produce cyanocobalamin, or sodium nitrite, which produces methemoglobin and subsequently cyanomethemoglobin. Thiocyanate can be toxic when it accumulates, and this can occur with prolonged infusions of SNP, usually over 1 week, or in patients with renal failure. It results in neurotoxicity, including tinnitus, weakness, confusion, and seizures. Other toxic effects of sodium nitroprusside can be via extension of its vasodilatory action, as it can result in severe hypotension, reflex tachycardia, raised intracerebral pressure, and worsening hypoxia due to inhibition of hypoxic pulmonary vasoconstriction. Rarely, methemoglobinemia can occur, which results in oxidation of the iron within heme from its ferrous to ferric state. This makes it unable to release oxygen, resulting in cyanosis but with a normal partial pressure of oxygen.
Great. Let's move on to another class of antihypertensive agents, that is calcium channel blockers. Could you please classify calcium channel blockers and give one example from each class?
Calcium channel blockers block the L-type calcium channel in vascular smooth muscle and within the heart. They primarily affect arterial resistance vessels, with only minimal effect on venous capacitance vessels. They can be classified as dihydropyridines and non-dihydropyridines. Dihydropyridines can be further divided by generation. First generation, such as nifedipine, second, such as felodipine, and the third, such as amlodipine. Dihydropyridines are highly selective for vascular smooth muscle and are therefore primarily used to treat hypertension. They have minimal effect on calcium channels within the heart. Non-dihydropyridines can be subdivided into phenylalkylamines, such as verapamil. This binds to the V binding site of the L-type calcium channel and is relatively selective for the myocardium, but less effective as a vasodilator. It results in reduced SA and AV nodal conduction, reduced cardiac contractility, and some vasodilatation, resulting in decreased heart rate and blood pressure. The second group of non-dihydropyridines are benzothiazepines, such as diltiazem. This binds to the D binding site of L-type calcium channels and is more selective for vascular smooth muscle compared to verapamil, but less selective compared to dihydropyridines. As it causes both cardiac depression and vasodilatation, it can reduce blood pressure without producing as much reflex tachycardia as dihydropyridines.
Can you please outline the mechanism of action of ACE inhibitors or angiotensin converting enzyme inhibitors and their pharmacodynamic effects?
So in order to understand the effect of ACE inhibitors, it is important to briefly outline the normal physiology of the renin-angiotensin system. Renin is released from the kidney in response to sympathetic stimulation, reduced blood pressure, and reduced sodium delivery to the macula densa. Renin then acts on angiotensinogen produced by the liver to produce angiotensin 1. Angiotensin 1 is converted by angiotensin converting enzyme, or ACE, to angiotensin 2, which has multiple effects, including vasoconstriction, especially arterial, which increases total peripheral resistance, cardiac output, and blood pressure. It also constricts renal efferent and afferent arterioles. It causes increased cardiac contractility and causes cardiac hypertrophy. It stimulates aldosterone, which increases sodium and water retention. It stimulates ADH secretion. It increases sympathetic activity, and it causes adhesion and aggregation of platelets. ACE also converts bradykinin to inactive metabolites. Bradykinin causes increased prostaglandin synthesis and vasodilatation, and therefore decreased peripheral resistance. ACE inhibitors therefore have multiple effects in the body by inhibiting the production of angiotensin II and by inhibiting the metabolism of bradykinin. Within the cardiovascular system, ACE inhibitors work as potent vasodilators, which reduces total peripheral resistance and thus reduces blood pressure. It also inhibits cardiac and vascular remodeling associated with chronic hypertension. Within the sympathetic nervous system, ACE inhibitors downregulate sympathetic activity due to decreased production of angiotensin II. Within the renal system, it promotes excretion of sodium and water due to decreased ADH and aldosterone stimulation. It also reduces proteinuria and stabilizes renal function, especially in patients with diabetes. Within the respiratory system, ACE inhibitors can cause cough, wheeze, and angioedema due to increased bradykinin.
Okay. Could you please classify beta blockers?
Beta blockers can be broadly classified into three different groups: non-selective beta antagonists such as sotalol and propranolol, selective beta 1 antagonists or cardioselective beta blockers such as metoprolol or bisoprolol, and finally mixed alpha 1 and beta antagonists such as carvedilol and labetalol.
Okay, let's talk about metoprolol. Could you please tell me about the pharmacology of metoprolol?
Metoprolol is a selective beta 1 blocker with no intrinsic sympathomimetic activity. It is available in tablet form both as immediate or sustained release, and also in IV formulations with a strength of 1 mg per ml. Metoprolol antagonizes beta 1 receptors, which reduces adenyl cyclase, reducing cyclic AMP, and thus reducing intracellular calcium. It has little beta 2 effects at doses less than 100 mg, and has an affinity 30 times greater for beta 1 compared to beta 2 receptors. Metoprolol has several beneficial effects. It has an anti-hypertensive effect by antagonizing beta 1 receptors, resulting in decreased heart rate and decreased cardiac output. It also inhibits the renin-angiotensin aldosterone system and thus results in decreased noradrenaline release from sympathetic nerve terminals. It has anti-ischemic properties by reducing myocardial oxygen demand due to decreased heart rate, contractility, and blood pressure. And finally, it's antiarrhythmic, reducing heart rate, conduction, and increasing the refractory period. Adverse effects of metoprolol mainly stem from extension of its mechanism of action and include bradycardia, hypotension, AV block, and bronchospasm in susceptible patients. Metoprolol should not be seized suddenly, as it may precipitate angina or myocardial infarction in patients with ischemic heart disease. In terms of pharmacokinetics, oral metoprolol is rapidly absorbed but undergoes significant first-pass metabolism, so it has a bioavailability of about 50%. This is increased in the presence of food. Metoprolol has a volume of distribution of about 5 litres a kilo and is about 10 to 20% protein bound. IV metoprolol has an onset of action of 1 to 2 minutes with a peak in 20 minutes. Immediate release oral metoprolol has an onset within 1 hour and its duration is dose related. Metoprolol undergoes metabolism in the liver by the cytochrome P450 enzyme system, especially via CYP2D6, which has large genetic variability. Metoprolol is eliminated in the urine as inactive metabolites with a half-life of 3 to 4 hours, but can be up to 9 hours in poor metabolizers.
Okay. So coming to another class of agent that is commonly used in intensive care unit is vasodilator agents such as hydralazine and clonidine. Can you please briefly compare and contrast hydralazine versus clonidine?
Clonidine is a centrally acting alpha-adrenergic agonist, which has an affinity to alpha-2 receptors 200 times that of alpha-1 receptors. Agonism of alpha-2 receptors in the brainstem results in decreased central sympathetic outflow and in the spinal cord increases endogenous opiate release. It is used for hypertension, as an adjunct analgesic, in opioid withdrawal, ADHD, and in the diagnosis of pheochromocytoma. Hydralazine is a peripheral vasodilator, but its exact mechanism of action has not been fully elucidated. Both clonidine and hydralazine are available in oral and intravenous formulations. Clonidine is well absorbed orally with a bioavailability of about 95%, whereas hydralazine is also well absorbed but subject to first-pass metabolism by genetically controlled acetylation, reducing its bioavailability to about 40%, depending upon acetylator phenotypes. Hydralazine is extensively bound to plasma proteins, unlike clonidine. Both are metabolized by the liver. Hydralazine is excreted as metabolites in the urine, whereas clonidine is excreted in both the urine and feces. The half-life of clonidine is about 12 hours, which increases in renal failure, whereas that of hydralazine is shorter at about 3 hours. Both clonidine and hydralazine causes decreased blood pressure, but hydralazine can result in a reflex tachycardia, unlike clonidine, which causes a bradycardia due to decreased sympathetic stimulation. Clonidine provides some sedative and analgesic effect and reduces opioid requirement when given intravenously. Hydralazine has minimal effects on the CNS, except for causing cerebral artery vasodilatation. Clonidine often has a diuretic effect, whereas hydralazine can cause fluid retention and is thus sometimes given with a diuretic.
Okay, thank you. That was a very comprehensive overview of antihypertensive agents in intensive care unit. So I gather that you have another joke for our listeners.
Yep, as usual, we'll finish with a joke. So why do the hypertensive bushwalkers always get lost?
Oh my gosh. To be honest, I don't go for bushwalking, and to be honest, I don't know the answer of this question.
Because they needed a better map.
Thanks, Maddi. That was very classic. Thank you very much. So in next podcast, we'll discuss about muscle relaxants in intensive care unit. Till then, see you and goodbye.
Thanks for listening. See you next time.